The resident appreciation dinner last night at Club Giroux. Thank you very much. It's my pleasure to introduce Dr. Toursarkissian, Boulos Toursarkissian. Went to the University of San Francisco for undergraduate, then went to the University of Kentucky, where he did both medical school and residency. While he was at medical school, he received no fewer than 9 named awards for excellence as a medical student. Graduated AOA. Oh, they're laughing. He did his fellowship at Washington University at St. Louis in vascular surgery, and then did an endovascular fellowship in France in 1997. Since 2002, Dr. Toursarkissian has been the chief of vascular surgery here. He's received approximately 6 Excellence in Teaching Awards from both residents and medical students, and was the 2007 recipient of the Presidential Excellence in Clinical Care Award. He's published over 60 peer-reviewed publications, 12 in the past 5 years. He's written 8 book chapters and given 90 invited national or regional presentations. And I think all the residents know Dr. Toursarkissian, but it is true that Dr. Toursarkissian is the busiest clinician in the entire medical school. And so it is my great pleasure to introduce Dr. Toursarkissian, who's going to talk on complications in peripheral vascular.
Thank you, Dr. He's always very kind to me. So, a lot of the stuff we do is endovascular, and I thought, since the talk was given last week on peripheral arterial disease, I thought I would talk about complications of the peripheral interventions. And when I think of those, I classify them into categories. The most common and ubiquitous is probably the access site complications related to accessing the vasculature. Systemic complications as a result of the procedure. Then there are complications that happen as a result of the intervention proper without the access issue. And then there are certain complications that are unique to particular procedures, and we will discuss some of them. Access site complications, these are them basically. Thrombosis of the access vessel certainly can happen. Pseudoaneurysm formation, retroperitoneal hematoma, which is quite distinct. This is from pseudoaneurysm. Infections at the access site, a vessel pseudo-occlusion, and I'll have an example of that, and then neurogenic complications can also happen from the access site. Vessel thrombosis. Whether a vessel that you access will thrombose or not is going to be related on how big a sheath you put in, and you guys know that we always try to put as small a sheath as possible. Obviously, a vessel that is very diseased is much more likely to occlude. If you don't use enough anticoagulants, that can be a risk factor for the vessel thrombosis, and the use of closure devices can be associated with the thrombosis of the vessel. For instance, this is the AngioSeal device on the right side, and that is the one that probably has the highest incidence of vessel thrombosis because it has a foot plate and a collagen plug, and the foot plate as deployed can pull up a plaque and cause thrombosis of the vessel. The risk factors also include a small vessel size, so if you have an access vessel that's less than 5 millimeter. Now also the over-vigorous compression, that's particularly important if you're accessing a groin where there's a prosthetic graft. Because if you compress it, that will result in, if you compress it to the point that you completely occlude the flow, that will result in thrombosis of the bypass graft. So whenever there's a bypass graft, you have to be very ginger in compressing it, and you have to have somebody listen to the foot to make sure you still have flow through the bypass while you're compressing it just enough to prevent the bleeding. Obviously, the longer you leave your sheath in, the higher the risk of thrombus developing around that sheath. So whenever you see that the sheath is going to have to be left in, it has to be hooked up to an infusion of an anticoagulant to prevent that. And closure device malfunction, that can happen with any of them. It's true the AngioSeal is the most common, but even little clips that get put in, if you compress them too hard, you can catch the posterior wall on them. Even the stuff that is extravascular, if you don't deploy it well, you can end up deploying the device intravascularly. The majority of these cases, when they're acute, are going to require an open surgical intervention. I know there are people who will try to stick the other groin, for instance, and go up and over and try to shave off the device. The problem, when you do that, you're basically leaving a hole that's going to be uncontrolled. And so, and if you end up using thrombolytics of any case, that could be a problem. So for us, who can operate, unlike others, we would usually, unless there are other reasons. Well, it's true. I mean, that if you can operate, you consider this as a failure, and then you're reluctant to call somebody who can. But for us, unless we have reasons not to, we would rather treat those open. Now, if it's a complication that is detected late, like a stenosis of the vessel or something, you can then try potentially, late meaning later than 6 weeks, you can potentially try to treat those endovascularly by going up and over. So, pseudoaneurysm. A pseudoaneurysm is a contained leak in the tissues. So there is no vessel wall around it. There's a pseudocapsule that forms it. And it happens about 1 to 2% of the time. It is more common when an intervention is done as opposed to a diagnostic study, and that is because with an intervention you're going to use a larger sheath and you're going to anticoagulate them more. It could be asymptomatic in the sense, oh, you know there's a little mass, or maybe the presence of a bruit that wasn't present before. Or it can be symptomatic in the sense that it can compress the adjacent nerves and cause paresthesias down the leg. I have seen cases of them large enough to compress the adjacent vein and cause a DVT. And sometimes those pseudoaneurysms can get infected. They're best diagnosed by duplex ultrasound. And a lot of time, the reasons why the pseudoaneurysm develops, it can be because of a closure device malfunction, or sometimes it can be because of inappropriate application of pressure. It is a common mistake for people who are not used to do this to try to compress at the point where the sheath enters the skin. And that is not correct. That is not the correct way of doing it. The reason for that is your skin entry point is usually 1 centimeter or 2 lower than your actual penetration site into the vessel. And therefore you have to apply the pressure if you're sticking retrograde a couple centimeters above the skin entry side, which is a very common error. And if somebody starts bleeding, then they compress the side where it's squirting out through the skin, and that still allows the blood to bleed into the tissues and create a larger hematoma. And the larger it gets, the more difficult it is to compress it. So those things, pseudoaneurysm, best diagnosed by duplex ultrasound. This is typical appearance of a duplex ultrasound. You have the two-flow in the vessel, meaning blood going in and out of the pseudoaneurysm, and this is usually what it will look like. This is the vessel, and this would be the pseudoaneurysm cavity. And those, the majority of them have a benign natural history. In the days before Plavix, we had done a study, and we had followed people who were not on anticoagulants other than aspirin. And we had watched a large series, over 200 pseudoaneurysms greater than, less than 3 centimeters in size. So granted, these were small pseudoaneurysms. And 85% of them will thrombose within 3 weeks if the patient is not anticoagulated and the size is under 3 centimeters. And in that study we had done at that time, there was no case of accidental rupture, because that's always been the concern, that you're watching pseudoaneurysms, could they rupture? In this selected series, I guess if you carefully select them, the risk of rupture is very low. Now, that was a study we had done before the days of thrombin injection, and now that the thrombin is available, the majority of these cases will get treated with a thrombin injection, which is just a regular thrombin we use in the OR with a small needle, and you insert the needle into the pseudoaneurysm cavity under grayscale, and then you inject it, and it usually takes 0.2, 0.3 cc's of thrombin, and that will thrombose the pseudoaneurysm. The advantage of that is that you usually don't have to worry about bringing the patient back, although there is about a 1 to 2% incidence of incomplete thrombosis that you won't detect, or recurrence. And so still, if you do that, it is still nice a week later to be able to get another duplex ultrasound and document the fact that the pseudoaneurysm has not recurred. Arteriovenous fistulas goes along with pseudoaneurysm, and sometimes they coexist. Now, unlike the AV fistulas, which are caused by gunshot wound or by high velocity traumas, those that are caused by catheterizations usually have a rather benign natural history, in the sense that it is rare for them to progressively enlarge to the point of causing significant steal from an extremity, or to the point of causing systemic manifestations such as congestive heart failure. But it is also true that if you observe them, they have a lower spontaneous resolution rate than pseudoaneurysms, which, as I said, the other one was about 85% 3 weeks. Here, when we looked at those, it was about 70% at a month. So in general, I don't feel as compelled to treat those as I do about the pseudoaneurysms that don't resolve. So we usually would treat them in cases where there's obvious steel of that extremity. A patient, for instance, had no claudication, now gets claudication because the fistula in the groin, let's say, is stealing away from the calf. If it enlarges, or if you have a decreasing ABI that's documented. There's again attempts frequently to treat those things by endovascular means with the placement of coils or stent grafts, but usually this is very difficult to do because they usually happen at branch points, and being able to put a stent graft, number one, in the groin is probably less than ideal because of the flexion that happens there and the fact that it makes your access later on more difficult. And also the stent graft has significant risk of occluding side branches. And so duplex compression has been tried, but it is rarely successful because it is hard to compress them effectively, and they're usually such a short connection that they're very hard to compress. So in general, if you're going to operate on those, it requires an open operation. And they usually tend to be fairly bloody because they do have a lot of venous hypertension that has developed for that. Now, retroperitoneal hematoma, I think I have a picture of that. Nope, picture didn't come up. So it's sort of what happens if you stick too high. So if you stick too low, you will tend to have a hematoma or a pseudoaneurysm. If you stick too high, you're going to have a retroperitoneal hematoma. And frankly, if I had my choice, I'd rather stick too low than too high, because these tend to be very insidious. These are very insidious and difficult to diagnose until sometimes it's rather late. So they're usually due to hypoxia. So again, the main point is when we stick, I always emphasize, we got to try to enter the needle right over the femoral head. If it's a brachial stick, over a bony prominence. And you want that because that's how you want to compress it. You want to be able to compress the vessel between your hand, your fingers, and the bone behind it. So if you stick too high, you're not going to be able to compress. Now, the majority will stop with the reversal of anticoagulation, but the majority is going to end up needing some significant transfusion. Whenever that is the case, you need to make sure that you don't have any active ongoing extravasation. And usually the best test for that is going to be a CT angiogram to show the extravasation. Now, if it does happen, this is one where you can certainly try to manage this by endovascular means, because to manage them operatively tends to be a rather significant bloody undertaking as well. So if you can stick the other groin and put a covered stent across the area of injury, and it will be a stent, obviously, by definition, above the inguinal ligament, because that's how those things happen, then that's a worthwhile consideration. If that fails and the patient doesn't respond after a few units of blood, then this is a situation where you often have to operate on. So, infection. Infection is always a concern whenever you've had a closure device that has been used. And there are, whenever the closure devices became frequently used about 15 years ago, the pattern of complications sort of had changed. We used to see a lot of frequent acute pseudoaneurysms. With the use of closure devices, you tend to see the complications develop a little bit at a later time. And so the scenario here is not necessarily the call that the guy just got cath this morning, but usually is this guy got cath 5-6 days ago and now has sort of a painful lump and maybe a little fever, maybe a little drainage in the groin. So I, at least to prevent those things, try to make sure that anybody who's going to get a closure device is going to get some prophylactic antibiotics. And if you're worried about an abscess, you're always going to want to get the duplex first, because you want to know if there's an associated pseudoaneurysm or not. And if there appears to be any abscess, I think it is better to surgically explore those people. It's probably better to find out that there's an abscess that's superficial, that does not track to the vessel, rather than let it fester. And the next thing you know, you'll have an infected vessel with wall damage. And so if the infection goes down to the vessel, you're often going to need to reconstruct it with a vein. And sometimes if it is extensive, you may also end up having to put a muscle flap to cover that. Now, the last one I talked to you about, the local complications, is a pseudo-occlusion. And that sometimes happens if you have a very small person who has a very small or a diseased vessel, and the sheath is occlusive. And so you complete your procedure, and then you're checking Doppler signals, as you should, in that leg where you accessed, and you cannot hear any Doppler signals. And that could be due to pseudo-occlusion of the vessel, meaning the sheath occlusive, or it could be due to distal embolization. If that sheath is still in, it is probably a good idea to do an angiogram of that leg to make sure that you have not embolized distally in that leg. And the sheath has to be removed as soon as possible. That can be a problem if the patient is anticoagulated, because if the patient is anticoagulated, and then it's difficult to just pull and apply manual compression. You can, and sometimes you end up having to, but then you have to plan about 40 minutes really of compression to get hemostasis. If the patient is not anticoagulated, it's a simple thing, you just remove the sheath. Now, if the patient is anticoagulated and you cannot use an extra vascular closure device, which would be the device you want to use if there's a small vessel size, then there is such a device which now has changed names, and I'm blanking on the name now. It's called the boomerang, but it's basically a little nitinol disc that is deployed through the sheath, and then you open the disc and you pull it against the wall, and there's a little clip, you adjust it against the skin. And what that does is basically it gives you a seal of the vessel, and it's sitting, as you see, inside the vessel, which remains open. And that allows you enough time to get hemostasis while giving you 2-3 hours for the anticoagulation to wear off. Now, obviously, if it's heparin, you can use protamine, but if you're doing cases under angiomax that you cannot reverse, that would be a situation where you want to try to use this device. So neurogenic pains, we get at least I get 2 or 3 consults a year about somebody who's had a cath and now has this constant pain in the groin. And they get a duplex, and the duplex is negative for pseudoaneurysm. It's very frustrating, and it's due to the interventional person sticking the nerve bundle while they're trying to attempt to stick the artery next to it. And it will be pain in the groin, and it will radiate it to the middle of the thigh with paresthesias. There usually are no motor deficits. It has to be pretty significant to have some hip abduction difficulties with that. So you need to make sure there's no insidious infection, pseudoaneurysm, and we treat them with Neurontin and give it some time. If it's not resolved after a few months, you're going to have the area injected, and we would refer this to a pain clinic for this. So that wraps up the part about the local complications. Moving on to the systemic complications, these are pretty standard. I'm sure everybody's familiar with it. Renal failure, myocardial infarction, allergic reactions, and vaso-vagal reactions. Renal failure, the risk factor, obviously chronic kidney insufficiency, stage 4, stage 5. Diabetics are more likely than non-diabetics to get that. Elderly people are more likely to get that. Somebody who's dehydrated, and maybe one of the most important risk factors for that as well is congestive heart failure, which I did not list here. Obviously, the larger the volume that of contrast you administer, the more likely the risk. If you use high osmolarity as opposed to low osmolarity non-ionic one, it's less likely. And people who have things like multiple myeloma of that sort have a higher risk of getting those complications. The majority of the time it is non-oliguric as opposed to oliguric. And usually it's not going to show up for 3 or 4 days. So the classic scenario, if somebody, you did it and the next morning they're not peeing fine, it's much more likely this person has a retroperitoneal hematoma and is volume contracted, as opposed to the contrast you gave him yesterday is causing his renal failure. Because it just usually doesn't happen. And it's kind of stupid for us, but we do it, and I do it routinely, check a creatinine the next day, and it looks fine and makes us feel better. But usually if they're going to get in trouble, it's not going to be the next day, it's going to be 3-4 days later. So again, if they're not peeing the next morning, the creatinine is high, look for some other reason, because it's unlikely to do that. Now, we give bicarbonate infusion for prophylaxis. The Mucomys has had a number of trials, and the small trials show benefit. The large prospective trials don't show any benefits. But it's relatively benign to use, so we do it, even though it doesn't have good evidence base. And the phenoldiprem is pretty much gone by the wayside, where the trials have not really supported the use of the phenoldiprem, which is selective dopamine agonist in the renal vasculature. So allergic reactions, so tachycardia, hypotension, respiratory distress, they may indicate anaphylaxis, which is very rare. In general, we always ask, as you know, for iodine and shellfish and contrast allergy before, and we usually would premedicate them with prednisone, we premedicate them with Benadryl, and an H1 blocker, H2 and H1 blockers before. If it does happen, and we missed it, and it does happen, obviously it's the usual management of anaphylaxis. Now, the milder forms are really much more common than the dangerous kind of anaphylactic reaction. And we will try to use a non-ionic contrast because that may have a slightly lesser incidence of allergic reaction than the ionic contrast. Vaso-vagal reactions, they mimic the anaphylactic reaction, but they're much more common. Usually it'll be some hypotension, bradycardia, and we would treat that just with fluid bolus, and sometimes atropine might be needed. Myocardial infarction is still possible in patients who have peripheral vascular disease, who undergo an endovascular intervention. Is of course much less likely than happening after an open surgical bypass. So the control of the pain and the blood pressure is very important before and after the endovascular intervention. The blood pressure control is also very important to reduce the likelihood of bleeding when you pull out the sheath. So you will notice if the patient is very hypertensive and you're planning on pulling the sheath, we will usually treat that and wait for it to come down a little bit before we pull the sheath. Now you got to walk a fine line, as you know we do. If you're going to pull the sheath, you don't want to just give them a large bolus of hydralazine, because then you pull the sheath, then they get hypotensive, and then you're sitting there wondering whether they're bleeding in the retroperitoneum or not. So you just use enough to bring it down to a reasonable level. Okay, procedural complication. This is probably the most interesting part that has the most pictures. And that's what happens with the complications. You can thrombose the vessel you're working on, you can dissect it, you can rupture it, you can create an arteriovenous fistula, cause distal embolization or distal vasospasm. While trying to put a stent in, it can end up in the wrong place. The wire can end up in the wrong place. If you're using a filter, that can create its own set of issues, and the stents can also have their own sets of issues, and I have examples of all of these. Now, thrombosis. Yes. Thrombosis is most often going to be due to an unrecognized dissection in the area that you are treating. And most often it'll be either at the proximal part of your target lesion that you're treating or at the distal end of the target lesion. Now, that's the most common reason. So if you see a thing that has thrombose that you just ballooned, that's the first thing you got to think of. And sometimes, however, it can be due to a patient having very, very poor runoff. So if you ballooned an SFA that ends into a blind popliteal that has only collaterals, that can happen because of that. Or it can be due to an undiagnosed distal embolization. If we have an example, distal embolization happens, you have a filter, the filter is full, you get no flow. So those are the things you got to think of. It's either a dissection or an embolization or a poor runoff. Now, it can also be, and that has been known to happen in this institution, of doing the procedure without anticoagulation. And I have seen at least a couple of those cases done in the cardiac cath lab. And then the whole thing, thrombosis, and that's due to lack of anticoagulation. But anyway, in general, usually we're going to give heparin or some other form of anticoagulation, anybody on whom we're doing an intervention. So let's say this thing happens, then the next thing you're going to do is take a catheter to aspirate this thing, one of those diver or pronto catheter or another thromboaspiration catheter. Try to aspirate some of the thrombus. We can use an angiojet, which is a rheolytic device that basically pushes in a lot of fluid and aspirates it at the same time, and to try to suck out the thrombus. And then we're going to, at some point in time in there, give a generous infusion of TPA directly into the vessel. Once you have managed to clear it, the next step, assuming it's not due to distal embolization or poor runoff, is you're going to proceed with stenting and a dissection. And again, if this thing is happening and things are not going very well, remember, check an ACT if you're using heparin to make sure they're adequately anticoagulated, because some people are heparin resistant. And in some cases, you may even empirically say, well, this is not working, why don't we just give them Angiomax or some other anticoagulant? Now, again, if this thing is not going well, you can check his stat platelet count, because, I have seen cases where it's due to acute HIT, obviously in somebody heparin-induced thrombocytopenia, in somebody who's already been exposed to heparin before. And so we may want to do that. But the problem with that is that's going to take some time to come back. So if things are not going well and you can't quite figure out why he's clotting, then you might want to consider empirically just giving them Hirudin or Angiomax or one of those other anticoagulant alternative. Now, dissection of the vessel. This is an example of a case that I had done where we had treated this SFA lesion, and there was very poor flow through the lesion, even though angiographically it looked relatively acceptable. And the runoff, when we shot the picture, even though it was sluggish, was still 3 vessel. And the inflow from the iliac arteries was good. So we had this lesion that we had ballooned, and the flow was very sluggish with it, couldn't quite figure it out. And out of curiosity, we ran an intravascular ultrasound in it. So by intravascular ultrasound, you can see evidence of a dissection. Here's the dissection area. And basically, we proceeded then to stent, and then how it looks after the stent, and the flow was better. So again, this is the most common scenario that it's going to be is a vessel dissection. Now, rupture of the vessel, it can be due to vigorous ballooning or putting the wrong size balloon in, a balloon that is too large, or more frequently I've had it because of complication of atherectomy. And it's going to happen more commonly if you have a heavily calcified lesion. If it is a total occlusion that you're recanalizing and you get into a subintimal plane, which the majority of the time we're going to end up getting in a subintimal plane before re-entering the true lumen. And so you can have a rupture. If an area is very heavily calcified and you're subintimal, it may just plain not open up. So sometimes we have to accept a focal inadequate result rather than run the risk of rupture. If a rupture is noted, the first thing you want to do is get a balloon across it to control the bleeding. The majority of the time, frankly speaking, a prolonged inflation of a balloon at 2 atmospheres, so we're not talking high atmosphere, you put a balloon across it and you wait about 10 or 15 minutes, the majority of the time it's going to take care of it. Sometimes it does not, but the majority of the time it's going to take care of it. Now, the patient is very heavily anticoagulated. We may decide to give a little protamine and try to reverse part of it. Now, if the angioplasty controls the problem, usually you want to stop. I early, would do that, and the angioplasty to take care of it, but it didn't look very great, and I wanted to put a stent in, and next thing you know, the stent starts up the bleeding again, and then when you have it stented, then it's not going to stop. Then you're going to end up getting in a situation where you want to put a covered stent. Now, if the angioplasty is not successful, you either need to put a covered stent across this area, which often may be available, often is not available, especially if it's after hours in certain places. There are no covered stents on the shelf. Or if it is a small vessel, such as a tibial, because stent grafts right now, the smallest one you have available is a 5 millimeter. So, 5 millimeter, putting that in a 3 millimeter vessel is probably not going to work. So in those cases, you may end up having to put coils in that vessel to embolize the vessel and get it to thrombose. Now, if the patient has another vessel going down to the foot, then you're going to be okay. If the patient had a single vessel runoff and you're obligated to put a coil in that vessel to control the bleeding, then things are probably not going to be okay. If it's a vessel that was totally occluded, that you tried to recanalize and you put coil in it, then chances are you're going to be perfectly fine and you're back to where you were. Now, stent grafting often requires sheath upsizing. So let's say we're trying to recanalize an SFA and we have a 6 French sheath up and over based on the principle that we want to use as small a sheath as possible. Then the stent graft is not going to go through a 6 French sheath. So now you have a sheath, 6 French, that's up and over with an 014 wire across it, because that's what filters are. Filters are an 014 wire. And now all of a sudden this SFA is bleeding, and you want to put a stent graft up there, which is going to require a minimum of a 7 French sheath. The 7 French sheath, if you pull your 6 French sheath, that's the wrong thing to do, because you're not going to be able to get a 7 French sheath to track up and over on an 014 wire. And so the last thing you want to do is sort of get excited about it and then lose the wire access. You pull it, and now you got an 014 wire going up and over, and you got no way of getting a sheath in. So in those cases, you sort of have very often to run another wire next to it, so that you have, let's say, an 014 and 018 wire, which is pretty sturdy enough now that you can take a larger sheath up and over on this without having lost your distal access, because that's the last thing you want to do is lose wire access across the area that is bleeding. So this is the SilverHawk device, which we use a lot. That excises the plaque, and that's an example of a perforation from the SilverHawk device. So this was the SFA we were treating, and this is after. This is not very HIPAA compliant. It has the patient's name from the VA too. Couldn't be any worse. So it has the large extravasation in the superficial femoral artery. And this is after we ballooned it. So you put the balloon in, you wait 10 or 15 minutes, you still have some staining, but you have no difficulties. Now, difficult thing to decide what to do is, this still got a dissection. This has still got a dissection, and now you have to think, do I really want to stent it and run the risk of it starting bleeding again, or do we just leave it alone? In that case, I left it alone, and it worked for a while, and then 2-3 months later, it wasn't working, so we did a bypass. So perforation. Now, perforation may happen with guide wires, and especially the glide wire. The glide wire is the hydrophilic wire, so they will tend to go in locations where other wires will not go. So if that happens while you're trying to cross a lesion, and you're not across the lesion, just inflate a balloon proximal to it. Once you inflate the balloon proximal to it, then you can try probing with the wire again through the tip of that balloon and see if you can get across it, and see if you can try a smaller wire. And if you're able to get a wire across it, then you can balloon it, and usually that will control the problem. Again, if that fails, then you have to try wires, and these are coils, and then these are some of the coils that have some hydrophobic material on it that's more likely to induce thrombosis. Now, this is an example of a lesion I was treating with the SilverHawk device, this lesion. And we did 3 passes, and so 3 passes I thought was very reasonable, not, so it's not overly aggressive, and this is the next thing we had. Now, we had an extravasation, and we put the balloon across it, and this is what I end up with. So I turned this basically from an uncontrolled extravasation to a pseudoaneurysm. This patient had no hematoma, and we put a stent across it. We did not have any covered stent. That didn't help any. That still had a pseudoaneurysm. And then we treated it with a covered stent. This is a stent that sometimes is available in cardiac catheterization laboratories. It's not commercially available, but it is available for coronary perforation. So it never hurts to ask to see if one of those is available, because it's as I said, something smaller than 5 millimeters. So they have them in 3 and 4 millimeters, so you could potentially use those to bear yourself out. Now, arteriovenous fistulas will also happen in the periphery. They can happen from either the wire, when you're trying to cause an occlusion, or from an atherectomy. We will treat those with a prolonged inflation. But stent grafting is rarely going to be needed, because the majority of the time those things are such slow flow arteriovenous fistula that they're going to thrombose on their own. So the majority of the time we tempted to leave those alone. Now, distal embolization. The best thing is to try to prevent them whenever possible. Chronic total occlusions are more likely to embolize. Calcified irregular lesions with heavy exophytics or the popcorn type calcification, these are the ones that are most likely to embolize. If you have a total occlusion that you're trying to cross, and you just minimally manipulate the wire, and next thing you know, the wire is across the occlusion, you always have to be beware that this just went too easy. And if it went too easy, then you have to think there might be thrombus associated in that location. So whenever there's a thrombus, which is frequently if the symptoms are less than 2 weeks old. If the symptoms are less than 2 weeks old, you got to consider there may have been some chronic disease and there's acute thrombus on top of it. So if the wire flies through or the symptoms are too short, then beware there might be some thrombus. Then if you go try to balloon those things, and if you don't put a filter across it, this is very likely to happen. So in those cases, if I suspect that is the case, I will try to get across it, put a filter across it. Once I have a filter across it, then I would either take the thromboaspiration catheter across this lesion, or I would take an angiojet device and try to suck out as much of what I suspect might be the clot, re-inject, see what it looks like, and then see if you can treat it. And if you're still not sure, you may have to run a catheter and run thrombolysis in them overnight. So this is an example of a pulpitular we were crossing, and this is an example of what happened from just crossing it, which is an embolization and knocked off the anterior tibial artery. This has sort of typical appearance of an acute embolization of the anterior tibial artery. So just from crossing it, Okay, even it may not have clot, just attempting to cross it can cause an embolization. And occluded stents are notorious for doing that. So if you have somebody that has a bunch of stents that have thrombosed and you're trying to get back across them, those have a very high incidence of just from crossing them causing an embolization. So you have to be ready to deal with that. And again, the usual manipulation of thromboaspiration, angiojet, and in rare cases, I think, there's been a couple cases presented here over the last year, you just have to operate on them to retrieve it. So these are some of those extraction catheters for people who haven't seen them. Basically, they're sort of eccentric on a wire, and you just have an opening here, and it's pretty low tech in the sense that you just take it in there and you put a syringe that you suck on, and you're trying to suck this thing back into this catheter. Now, obviously, you want a big catheter. The problem, a big catheter is not going to run all the way down into the tibial, so they come in different sizes. You got to make sure you have the different sizes so you can suck them out. Now, distal embolization, if a critical vessel is affected, obviously you have to treat. And so for instance, that example of the anterior tibial artery I showed, you can't just take a catheter, push in the popliteal, and infuse TPA, because it's going to run down the vessels that are open. You have to selectively get into that vessel so you can administer the TPA as close to the site of the occlusion as possible. Now, there's Fogarty's over the wires that are potentially available, and in some cases where we didn't have anything, we've even used filters. A filter, which is to design pre-embolization, you cross across this lesion, you open the filter, and you drag the filter back, kind of using it like an embolectomy catheter. Now, if there is a small residual lesion, sometimes you just have to try to stent it against the wall. So if it's partially occlusive and you can't get it out, you may just put a little drug-eluting coronary stent in the tibial trying to tack this little embolus against the wall of the vessel. Now, if somebody has a trash foot, and this is one example of a trash foot that's gone too long, basically. And in those cases, in other terms, they have this mottling reticular appearance to the foot, and they may have a lot of pain in the toes, but there's still very good Doppler signals in the foot, or even a palpable pulse. In those cases, usually we're going to treat those with anticoagulation, because those are the emboli, very small, gone too distally, we cannot retrieve them. Now, vasospasm is something that can happen either from a wire or a filter. Usually, the less calcified the vessel is, the more likely the vasospasm. This is an example of a vasospasm from a carotid artery. Now, whenever there is a vasospasm, you always have to be wary as to whether there's associated thrombus. So we may empirically administer some TPA. We will give some nitroglycerin, high dose, directly into the vessel. Now, this is an example of what happened. We were stenting this carotid, and we had the filter in this location. We done this looks fine, and then it looks like this. You've got to be aware not to give too much nitroglycerin if it's an intracranial case, because then they'll have a headache. And then you don't know if you cause an intracranial bleed from restoring the flow, whether it's just your nitroglycerin. So in those cases, I will tend to use lower doses than I would if I'm doing a peripheral case. And again, you've got to watch the blood pressure, because you will see sometimes if their blood pressure is 120 and you give them 600 mics of nitroglycerin. So you do that at the same time, you got to tell somebody to give them a fluid bolus, so you don't have a problem with this. Now, stent displacement. So this is common in situations where we're going up and over, there's an iliac stenosis, we want to treat the SFA. And a common mistake is okay, you're going up over, so you're going to stent the SFA, stent the iliac, and then continue down the SFA. But the problem to do that, then you're going to have to put a stent fresh across the iliac, and then cross that with a sheath to get your sheath down to the groin. And so it is better to try to avoid crossing a freshly deployed stent, because he hasn't had a chance to heal, and then just pushing the sheath across it may move it. So in those scenarios, we may balloon the iliac, even though it may dissect, as long as it's flowing, put the sheath across, work on the SFA, and then stent on the way out. Now, the other thing to beware is if there is a pre-existing stent, it is sometimes common for those stents to not be exactly opposed to the wall. This is an example of what we call fish scaling. So the lesion is calcified and irregular, and the struts of the stent, some of them stick inside the vessel. So now you're going down with your wire. The wire may go into a stent, into a strut of the stent, out of it, and it looks fine. And then you try to pass your sheath in, and next thing you know, it's not passing. It's not passing. Whenever it's not passing and there's a stent there, you have to to worry as to whether the wire is going in and out. So in those cases, you may have to pull back and try to redirect it. The other thing you can do is you can put a balloon just at the beginning of the stent, and hopefully that will center the opening of the wire in the center of the balloon, and then you can be center line and then try to advance your wire. Now, stent has restenosis. They get restenosis, and then we often treat those with either angioplasty or atherectomy to excise it. You have to be very careful when you're doing atherectomy within a stent, because if you're too vigorous, next thing you know, you can be cutting part of the stent. And now, this is an example of such a thing. Now, in those cases, sometimes if you have a laser available, that might be a better option for an occluded stent that you're trying to recanalize, because you don't run the risk with the laser of excising part of the stent. Now, so this was an example what we did, and basically what happens, it caught onto the stent, that atherectomy device, and unraveled the stent. It wouldn't come out, and when I pulled, basically the stent unraveled, and I kept pulling until basically we had pulled most of the stent through the sheath up and over. The vessel thrombosed, we still had wire access, we were able to open it up. And so you have to be very, very careful when you do those things. If the device doesn't go, not to push. The thing to do actually is to back up immediately. And you want to use a less aggressive device. Now, wire complications. We get a lot of those consults where somebody stuck the groin, they're going up, and their wire goes subintimal. That's usually a retrograde dissection. That's usually not going to be a problem because the direction of flow is against it. It's going to tack it down, so often you just watch it. Now, if it's a dissection that's antegrade, meaning happening in the direction of the flow, it's often going to require stenting to control that and to prevent propagation of it. But to be able to do that, the distal tip of your wire has to be back inside the true lumen. Otherwise, you're stenting the dissection open, you're going to occlude the vessel. Now, perforation, again, with hydrophilic wires can happen. So the key point is when you're advancing the wire, you always want to see when the tip of it is. I mean, the classic scenario is you stick the groin, you're running up with a glide wire, and boom, next thing you know, this thing is across the kidney. Because the wire just went and it's got a curve and it enters the renal artery and you pushed it, next thing you know, I mean, we just had a case like that where somebody else did it at St. Luke's, and it was actually in the inferior epigastric artery. And so it went across it, and it's a wire, and it runs up the inferior epigastric artery, next thing you know, it's perforated. Now, subintimal placement of the wire, as I said, you have to have the tools to make sure it's re-entered. And then this is the deal about the stent. So very often, if you want to cross a stent, it's sometimes better to use a wire that has a J-tip, because if it's a J-tip, it's going to stay in the lumen. It won't go between the struts of the wire. Now, these are the re-entry devices. There's a couple devices on. There's one, now there's three actually, called the Outback. This is a Pioneer catheter. It's based on intravascular ultrasound. And basically, you can run this device in, and you can see where the dissection plane is, where the true lumen is, and you can redirect this needle to go into the true lumen, and you pass your wire across it. So you can re-enter. And you would use it if you're trying to cross a total occlusion, and you can get your wire across it, but you cannot re-enter the true lumen distally. So this is an example of such a case. Now, there's another device called the Outback catheter, and this one doesn't use intravascular ultrasound. This one uses just angiography, and it's got the little L, and the little L points in the direction where the needle's going to come out. So you can see we've come up from above. This catheter is subintimal, and you would poke your needle in here, and hopefully it's going to re-enter. Now, obviously, the more diseased the vessel is, the less likely you're going to be successful re-entering that area. The more heavily calcified, the less likely it's going to be. And if you played around for half an hour with a wire, made a big dissection plane, and now you decide it's time to pull up this thing, that's not going to work. Because now the dissection plane is large, and you stick with the needle, and it keeps bouncing around in the dissection plane. So if you're going to use those devices, you want to use them. You try for a couple of minutes, the wire doesn't go, get the device out. If you wait too long, it's probably not going to work. Now, complications of filter. This is a filter that is full of debris. So it can cause thrombosis of the vessel, spasm. I showed you an example of that. If you have a lot of debris, it will overfill the filter and it will spill out. The other thing that's critical is those filters, you got to make sure you don't deploy a filter inside the stent. Because this filter has struts, the stent has struts, next thing you know, they're going to be tangled. I have examples of that. Now, and the other thing is the majority of those filters, except for one on the market, once you've retrieved it, you've retrieved the filter and the wire, so you've lost your wire access. So you got to think about that if you're ready to, when you want to retrieve the filter, if you're ready to, you're done with it, that you don't need the wire access. Sometimes if you don't want to do that, you may be able to take a large bore catheter and then just pull the filter through the large bore catheter. Then you put a wire through that large bore catheter, you've maintained access. The problem with doing that is to pull that filter through a large bore catheter. If it's got a lot of debris in it, you may milk the stuff out. So if the filter is really, really full, you're not going to be able to do that. In those cases, you might want to take an aspiration catheter, put it right next to the filter, aspirate as much as you can to sort of decrease the burden, the load that is present in the filter, and then retrieve the filter. Now, this is an example of a carotid. We had a filter up there. We have the stent put in. We do an angiogram, boom. There's no flow. There's no flow, and the thing is, in those cases, you worry. If this were a peripheral case, potentially you could say, well, I'm going to retrieve it. But in those cases, I mean, if it embolizes up their head, that's a major problem. So this is an example where you're going to run up your aspiration catheter, then you're going to retrieve it. When you retrieve it, I make that point for all people who work with me, you want to just close the filter. You don't want to retrieve it completely because, again, these filters, while they catch stuff, if you push the stuff, it's going to milk out of the filter. So you just want enough to close it that you don't push the stuff out, but enough that it won't embolize while you're retrieving it. The other thing is you got to be careful about mixing systems. This is an example of a complications where at the VA when we were using different kind of, one guidant stent with an emboshield wire, and as we deployed the stent, the deployment system on the stent moves forward and it caught on to the filter and it would not let go. And so now we had the delivery system of the stent with the filter attached to it. I think a month ago there was a case here presented where they were doing a rotational atherectomy on a filter, and the filter the atherectomy device kept spinning, caught the filter. So whenever you mix systems with different brands from different people, you have to be aware all sorts of complications happen. So this thing caught on to the filter is deployed, the stent is deployed, and now this thing is attached to the filter, won't come out. Now, we tried to basically retrieve it, and what happens is we pulled enough that the filter then came down. Now, not only the filter was attached to the deployment system, but it was also stuck in the stent. And so then we ended up basically having to, the filter was stuck in the stent, and then we ended up having to operate on this thing to retrieve it. No, so other complications that you can see happen is that if during deployment or passage of a stent, a balloon-mounted stent may come off the balloon or the balloon may rupture. So what ends up happening now is that you have a stent that is partially deployed that's floating on a wire. And it's not opposed to the vessel because, let's say, the lesion was heavily calcified, the balloon ruptured when you try to deploy it, or the lesion was tight and you thought it was large enough to advance your balloon-mounted stent, but as you tried to advance it, the stent slipped off the balloon. Usually the best option in those cases is just deploy the stent wherever it is, as opposed to try to get that same stent to the lesion. And sometimes what you have to do is you have this stent which is partially deployed floating on a wire. The balloon is ruptured. Take out the old balloon, advance a very low profile balloon, even though an undersized one. So let's say it's an 8 millimeter stent that you were trying to deploy. Just advance a low profile 4 millimeter balloon, put it over in the area where the stent is, open up the stent enough, and then go to a next size larger to the point where you're able to get gradually larger balloons to go in over the wire inside the stent and deploy the stent wherever it is. Now sometimes you can, if that doesn't work, you can get a large sheath and then try to pull the whole system out, but then you lose access. Sometimes if you're going to snare the stent, which is the other option, you're going to have another sheath put in next to it. Because the snare, if you try to put it on the wire, it won't cross it to be able to capture it. So, but these are things you can do to try to recapture the stent. This was an example of that happened again at the VA then, and where the balloon came off the stent. And we did exactly this. We dilated it in place, and it ended up fine. Now, this is an example where somebody was putting a coronary stent in, and it slipped off and somehow ended up in their SFA. And we got consulted on it. In those cases, what we ended up doing is taking a large stent in the SFA and just stenting the coronary stent against the wall of the vessel. We had another example where we were doing intravascular ultrasound, and the probe on the intravascular ultrasound came off the wire and was stuck in the iliac vessel. It wouldn't come out. And we just put a stent and plastered it against the wall of the iliac. So late complications, restenosis, that's the most common complication you're going to see. Thrombosis, edema of the leg, that usually happens because of reperfusion. Neuropathic pains, it's particularly common if you do a subintimal recanalization long vessel, you irritate the nerves next to them, they will often have a lot of burning and tingling along the course of the stent. Stents can get infected. They can also cause aneurysmal degeneration. Restenosis are the most common complications. Options, you could do laser, you could do an atherectomy, you can do cutting balloons, regular balloons, restenting. The thing that is very common in Europe that we don't have available here is drug-eluting balloons. So basically those balloons are coated most commonly with paclitaxel. And there's some good data to suggest that those balloons prevent restenosis by preventing proliferation of the smooth muscle and intimal hyperplasia. Now again, the stent thrombosis, when you cross it, beware of the runoff and the risk of embolizing. Now this is an example of a late complication at the VA. This was a cirrhotic patient who was not in any shape, tolerating a procedure, had gangrenous changes in his leg. He had this total iliac occlusion. He had this SFA occlusion. The profunda you can see just reformed here. And then he reformed a popliteal down by the knee. And what we did is we did a cut down on his popliteal, put a sheath retrograde, and recanalized basically all the way from his popliteal all the way up into his aorta. We had to use one of those re-entry devices to re-enter into the aorta. And his ABI went from 0 to 0.9, and the toe amputation healed. Then he came back 2 months later, septic, with a large fluid collection that tracked from the iliac artery to the popliteal artery. So to fix that, you would have had to go into his belly, excise the iliac vessel, excise his femoral vessels, and then either do a high amputation or a hip disarticulation. We elected to do nothing, and that was the end of it. And so other findings that can be associated with infection include an aneurysmal degeneration of the stented segment, vessel rupture, we certainly have seen some of those, and distal septic emboli can happen. Now, leg edema, as I said, is not uncommon. A small amount of fluid along the course of a recanalized vessel by ultrasound is not particularly uncommon, is not necessarily indicative of an infection. And as I said, the burning pain along the medial thigh. So that's basically what I have. I still have a few minutes if anybody has any questions.